Hello guys, my name is Han Zhang. I'm a gastroenterologist, and today I'd like to talk to you about the very important topic of colon cancer screening and colon polyps made simple. I want to talk about a very important concept, which is that if a patient comes in and undergoes a colonoscopy, that colonoscopy is normal, then they have a lower risk of developing a high-risk polyp or colon cancer in the future, and as such, they may return for the next colonoscopy later on, such as in 10 years. However, if a patient has a colonoscopy and that colonoscopy shows a polyp that is what we call a high-risk polyp, whether it's size or number or histology type, then their chance of developing another high-risk polyp or colon cancer in the future is higher. So then they must return sooner, such as in 3 years or 5 years, or depending on the specifics of the polyp. I remember being an internal medicine resident studying colon cancer screening and colon polyps and being very, very confused because there were so many terminology being thrown around. Sessile polyps, sessile serrated polyps, tubular adenomas, tubulovillous adenomas, pedunculated. It was very confusing, so I'd like to break this down for you to make it as simple as possible. Now, what's important when trying to differentiate all of these characteristics is that differentiating it between endoscopic descriptions versus pathologic or histologic descriptions. Endoscopic descriptions are what you would see during the colonoscopy itself. You may have a polyp that you would consider sessile, which is a relatively flat polyp, but there is this small dome-shaped feature to it, so it's not truly flat. You can also have a pedunculated polyp, which is essentially on a stalk, or you can have a truly flat polyp, which can sometimes be difficult to see. And there are other characterizations that are possible during that can be seen during colonoscopy. Now, what happens once you see the polyp is that usually this will be removed by the endoscopist using multiple methods such as a biopsy forceps or by using a snare polypectomy technique. And once it's removed, it will get sent to the pathology department. They will review it under the microscope and perform various staining. And they will tell you the diagnosis, a pathological diagnosis, such as polyps that have low or no risk called a hyperplastic polyp. And on the other hand, they may say that this is a high-risk polyp, such as what we call a villous adenoma or a tubulovillous adenoma, a traditional serrated adenoma, a tubular adenoma with high-grade dysplasia, or a sessile serrated polyp with dysplasia. And in the middle, you may have two common categories, which are the tubular adenoma. Now, note that tubular adenoma is also known as just adenoma by itself. So if someone just says adenoma, most of the time they are referring to a tubular adenoma. And then the other part is that you may have a sessile serrated polyp, which is also considered a medium risk. And while the high risk polyps usually will come back sooner, such as in 3 years, the medium risk polyps, the patient will come back depending on the number of polyps and the size of the polyps. And we'll look at some examples here. Now let's take a look at the latest guidelines on colon cancer screening and polyp surveillance. So assuming the colonoscopy is a high quality colonoscopy with good prep done by a good endoscopist with good technique, then the interval that they will return are listed here. So for example, if you take a look on the left side here, if a patient has a normal colonoscopy without any precancerous polyps, then they will return in 10 years, assuming this is an average risk patient. If a patient has 1 or 2 adenomas, now again, remember, adenomas usually points towards tubular adenomas, and 1 or 2 adenomas, then they will return in 7 or 10 years. Importantly, these adenomas are less than 10 millimeters in size. If a patient has 1 or 2 sessile serrated polyps that are less than 10 millimeters in size, then they would return in 5 to 10 years. If a patient has 3 to 4 adenomas or 3 to 4 sessile serrated polyps that are all less than 10 millimeters, then they would usually return in 3 to 5 years for the next colonoscopy. And then lastly, if a patient has any of the advanced polyps that we mentioned before, such as adenoma with villous features or tubulovillous histology, or adenomas with high-grade dysplasia, or sessile serrated polyps with dysplasia, or traditional serrated adenomas, they will return in 3 years. But also take note that if you have just regular adenomas or sessile serrated polyps that are more than 5 in number, or if they are greater than 10 millimeters in size, then they would also be considered advanced polyps, and the patient would also come back in 3 years for the next colonoscopy. Lastly, if a patient has more than 10 adenomas, then they should come back in 1 year. So let's take a look at some examples. For example, if you have a patient with 2 polyps and that gets sent off to the pathologist and they let you know that those polyps are considered hyperplastic, when would be their next colonoscopy? So in that case, 2 polyps that are small, 2 millimeters in size, that are hyperplastic, they would come back in 10 years because it's less than 20 hyperplastic polyps that are less than 10 millimeters in size in 10 years. Now, what if you have 3 5 millimeter polyps that are removed? Those polyps turn out to be tubular adenomas. Then what would be the interval that they would come back in for the next colonoscopy? So with 3 smaller polyps that are removed, that are tubular adenomas, then they would come back in 3 to 5 years for the next colonoscopy. Another example, if a patient has 5 polyps removed, they're all 5 millimeters in size, so smaller polyps, 5 of them. The pathology shows sessile serrated polyps. So let's take a look. So 5 polyps that are sessile serrated polyps, that patient will come back in 3 years for the next colonoscopy. And lastly, if a patient has 1 polyp removed, that's 15 millimeters in size, so that's on a larger scale, that is removed, and the pathology shows tubulovillous adenoma, when would they come back? Well, if they have a 15 millimeters, that would qualify here, greater than 10 millimeters, and then they have a tubulovillous adenoma, they would come back in 3 years. One good way to remember this is that the villain is always bad, so that's a high-risk polyp, and you would want to bring them back sooner. So they would come back in 3 years. As you can see here, the time that the patient comes back for the next colonoscopy depends on the type of histology as well as what you see on endoscopy, specifically the number of polyps and the size of those polyps. Now, what I've mentioned here applies mainly for patients who are at average risk. There are some caveats that I did not mention yet that I will go through here. So if a patient has a family history of colon cancer or advanced colon polyps, that does change their risk. So to go back, for patients who are average risk for colon cancer screening age, meaning they don't have any specific disorders, they don't have inflammatory bowel disease, they have no family history of colon cancer or colon polyps. Those patients usually begin colon cancer screening from 45 and they can end at 75. Between 75 to 85, that tends to be individualized, whether or not they should still continue colon cancer screening. Now, what if a patient has a family history of colon cancer? So if a patient has family history, then that changes their risk profile, so they may need to come back sooner. The guidelines state that if a patient has a first-degree relatives, that means children, sibling, or parents with colon cancer or advanced colon polyps. Remember what advanced colon polyps stand for, the specific types such as a tubulovillous adenoma or polyps greater than 10 millimeters in size. If those family members are less than 60 when they were first found to have those polyps or had the diagnosis of colon cancer, then the patient should start at age 40 or 10 years before the youngest relative when they found whether the polyps or the colon cancer. And then in addition to that, those patients should undergo colonoscopy at most every 5 years. So even if they had 1 tiny polyp or no polyps, they would still come back in 5 years instead of 7 years or 10 years. If a patient has a first-degree relative with colon cancer or advanced colon polyps greater than 60 years of age, then they would still start early. They would start at age 40 or 10 years before the youngest relative. But what's important to note is that the guidelines recommend average risk screening. So they would not come back every 5 years. They can still come back every 10 years if that patient does not have any polyps. So note the difference is the age at which the family member was found to have colon cancer or advanced colon polyps. And lastly, if a patient has 2 first-degree relatives at any age who had colon cancer, advanced colon polyps, then they would also start at age 40 or 10 years before the youngest relatives, but they would also come back at most every 5 years. So note the importance here, the focus on the age, and note the focus on the first degree relatives. The guidelines do say that if it is a second degree relative, then they recommend keeping that patient as average risk for colon cancer screening purposes. Now, we talked about family history. There's another part, which is personal history. If a patient has a personal history of advanced polyps, then they are at a higher risk in the future of developing advanced polyps or colon cancer. So again, what are advanced polyps? So adenomas greater than 5 in number, sessile serrated polyps greater than 5 in number, greater than 10 millimeters in size, or if they have any villous features. And again, think of villous as a villain, as evil, and they will have to come back sooner. A sessile serrated polyp with dysplasia, or a adenoma with high-grade dysplasia. Anything, whenever there's a dysplasia, you want to pay more careful attention to see if that is a patient you must bring back sooner. And then the patient with traditional serrated adenomas. These are considered high-risk polyps or advanced polyps. So those patients must come back initially in 3 years for the first colonoscopy, but because they're at higher risk, even subsequent colonoscopies, at most, they should come back no more than 5 years. So for example, if a patient has a 15 millimeter polyp that is discovered and removed, that turns out to be adenomatous, they will come back in 3 years, but then that next colonoscopy, if that is normal, they will still come back in 5 years for the next one. So that is another caveat. There are some other caveats that we didn't discuss, such as if a patient has inflammatory bowel disease, if they have a polyposis or cancer syndrome, if they have a history of colon cancer themselves, or if the colonoscopy was a low-quality colonoscopy, such as with poor prep. Those would also alter the timing in which the patient would come back. And lastly, there are other common methods of colon cancer screening that are recommended in the guidelines. For example, FIT test, which should be done annually, the Cologuard test, which could be done every 3 years, or the CT colonography test, which could be done every 5 years. There are others, but these are some of the more commonly done ones. It's very important to note that these tests are only indicated for patients that are average risk patients. So you wouldn't bring a patient who has a personal history of advanced polyps to undergo this test, or a patient with a first degree relative with a history of colon cancer to undergo these tests. And if any of these tests lead to a positive result, then the next step would be a colonoscopy. And lastly, while this is not in the guidelines yet, this is something coming down the pipeline, which is cell-free DNA blood test for colorectal cancer screening. It is FDA approved, but we still need more data to know how to best use this. With that, I'd like to thank you for your attention. Remember, surveillance depends on the patient's history, the size, the number of polyps, and the histological classification. The idea is that the higher risk of the polyps that are removed, the sooner you want to bring a patient back for a colonoscopy. For more information, please Google American College of Gastroenterology colon cancer awareness educational resources for some great advice. Remember, this video is for educational purposes only. For more questions, talk to your attending, your primary care doctor, or your gastroenterologist. Thank you so much.